but I've heard that we have a lot of visitors on our online portal. So I'm the chairman of this section, and first I'll give the floor to myself and will present to you. I hope that my presentation is working well. Today, I'll try to talk about the main trends in HIV research, but first I would like to mention why we need them. We see some quite successes emerging in the field of the fight against HIV. The next slide, please. Having some troubles clicking on the slides. Okay. So, for more than 10 years, we've been having a strategy in the fight against HIV infection. This is the strategy called Test Up, Test and Treat. And it was proposed and suggested back in 2009. Currently, this is the main strategy. What is the gist of it? We have to diagnose the HIV infection among everybody who are infected, and we have to apply antiretroviral therapy on a lifelong basis, so the life expectancy will increase among those patients, and then they can live for 30 and another 50 years. And we can expect that the number of infected cases in 50 years will be going down to 0. And those who are infected right now, for example, they currently can be 10 years old, they will live up to 75 years. And we can say that in 75 years, we can say, or will be able to say, that we'll have 0 cases of new infections. And this program and strategy has spread quite a lot. The main idea of this is that we have to get tested. If anybody is HIV positive, then the treatment should be applied, and it all will end quite well. And if we take a look at the current state of affairs in the reality and at the development of this campaign, we do see that the number of newly diagnosed cases is decreasing. But still, we've seen a recent publication saying that 1.7 million new cases appeared in 2019. Unfortunately, this is not in line with the concept that was approved before, and it all happened before COVID. So we expected the number of new cases to be less than 500,000 once, but this figure in reality is 1.7 million. And some groups even experienced the growth of the newly infected and diagnosed cases. So unfortunately, this program is not going as it was expected. And there is another strategy, the global strategy on AIDS, and it is about to decrease the number of new cases up to 370 by 2025. And the number of deaths should also decrease quite significantly. But if we calculate how many new cases we will get over this 5 years, we'll add 4 million of new cases. And here you can see the Russian state strategy on the fight against the spread of HIV in the Russian Federation. It is adopted up to 2030. And by 2025, according to this strategy, we will indeed, or should indeed, experience the decrease of the new cases up to 58 new cases per year. And as to this plan, according to this plan, minimum, we will get 344,000 newly infected cases. And by 2030, we expected to get the figure of 656,000 new cases. And speaking worldwide, it will be equal to from 3 to 5 million of people HIV positive. And in Russia, we will get an additional number of more than 500,000 of people, and we will have to treat them over the upcoming 75 years. And this strategy, check and treat, of course, it will decrease the death rate connected to HIV, but it will result in the increase of financial, organizational, labor costs that are connected to the organization of HIV treatment. You do understand it all yourselves. This strategy also has some weaknesses, and they demonstrated themselves quite clearly during the coronavirus pandemic. First, it depends on the loyalty and readiness of the government, whether the government will allocate money or not. Some governments do not allocate any finance, they are just hoping for the financial aid from rich countries, so to say. This is not a very good thing to hope or to be relying on, because this is a very subjective element. Then there is also an issue of the financial stability, reporting, as well as whether we'll be able to build some loyalty here. And if there is no loyalty and its confirmation, then we can face a situation of the worsening of the situation. So probably we have to suggest something else. And subjectively speaking, I don't think that anybody who are HIV positive, I don't think that they would like to administer antiretroviral medication. Today, we've had a report on the Coalition on the Readiness of Treatment. Well, the number of pills that should be administered per day is decreasing, but this does not apply to everybody. And still, people have to administer a lot of pills per day. And of course, it all depends on the cost. So 1 pill per day will cost more than 13 pills per day. So the problem is still there, and it persists to be quite serious. So we definitely need to develop our scientific research as well as to finance it. And this point is somehow missing both in the global strategy and in the Russian state strategy of fight against HIV. Well, first, this is about non-specific prevention. We have to provide information to train. The previous section has told us about it quite clearly, and the International Labour Organization said that they conducted some work in some professional teams. And still, the first question that should be discussed with people is, do they differ, HIV and AIDS? Does any difference exist for them between these two states? And so people do not know. And we also discuss on how to drop the strategy. How should we inform the population, or we'd better train them? Well, informing and training, those are different elements. If you just say on the website, well, be afraid of AIDS, this is informing. But if you tell the people how to use condoms, this is more about training. Whether we'll be conducting this or not, this is all quite complex. Then, in addition to that, what methods are efficient, which are not that efficient, how to influence the population? These questions are all quite complex. Well, the issue of circumcision, for example, for some countries, this is quite a pressing and relevant issue because it can decrease the infection risk by 60%. And, well, in many countries, nobody will do any circumcision. However, our chief sanitary physician in the past called upon everybody to do this, but it wasn't paid much attention to. So all these aspects should be reviewed and supported scientifically. The next point here is the specific prevention, what we usually call vaccination, but currently there appeared another area of studies, the passive immunization. So we can also produce the highly specific antibodies against HIV. We can inject them and proceed with the prevention. Then Genoprevention, it's quite common and known. So here we could use some genetic therapeutic medications. I'll touch upon this a little bit later. And when it comes to the cure and treatment itself, definitely we need to improve the current antiretroviral therapy. It is discussed quite a lot, but first and foremost, we have to develop the methods how to cure the HIV infection. This is the most important task of ours. Well, getting back to non-specific prevention, this is a very good example. Well, we've been teaching our population for 30 years that one should use condoms, but for some specific groups of population, it turned out to be very difficult to perform, and some so-called specialists say that condoms are not a protection. And actually, we can compare the situation with condoms with the situation of masks. Well, a lot has been said that masks can only worsen the situation and infection, and then the whole world finally came to the conclusion that masks is, before the vaccination, one of the most common and efficient ways of not getting infected. So this is another example how we can also make people use condoms. Pre-contact prevention. I believe that here it's quite clear. Different medications can be administered. Some of them are registered, some of them are not registered yet. If, once again, I refer to the previous session that we participated in, there are a lot of organizational challenges indeed. However, there are some prolonged medications, well, you can get one infection for the upcoming 6 months, and you can get any infection except for HIV. And also passive immunization, as I've said, those are protective antibodies. One injection can result in a couple of months of defense and safety. Then specific immunoprevention vaccines. This is the favorite topic of our researchers. They are quite keen about it. But as you know, protective immunity cannot be developed naturally when we talk about HIV. We have to come up with something specific, and 35 years have passed, but no vaccine has been developed yet. Last year, there was a very promising vaccine, and the efficiency of 30% was given last year, but the data has shown that the placebo group and the control group had the similar number of infections. But this research is still undergoing, and perhaps we could see some effect in 2 years, for example. There could be some difference appearing, but as of today, the research has stopped, and only those are monitored that have already been vaccinated, and that's all. And there are some more vaccines coming. The combinations of antigens are quite complex there. And thanks to generic engineering, we learned how to produce them. These vaccines are quite promising ones. And upon the monkey model and their own virus of immunodeficiency, we've seen that the results after the vaccination are quite good, the protection up to 90%. But currently, these vaccines are undergoing trials. And, well, there is some delay connected to a vaccine caused by the coronavirus. But next year, I expect us to get some very interesting data on vaccines and medications. The chemo medication with a prolonged activity also has been working. So cabotegravir, you all know about it. Currently, we are studying isulfavirin, and very interesting medication, capsids inhibitor. And this is not an injection, but this is per oral form, once per week. And if we talk about the intermuscle injection, when it should be done once per 6 months, the results are quite promising. And it could also be combined with the medication manufactured by another company. And it could be that one injection should be done just once per 6 months. But still, it is all undergoing trials, and I don't see it coming very soon. Then the new medication forms, such as antiretroviral medications that are in the liposomes, so they can be delivered right in the cells, and it takes them a lot to get the release, so it produces the prolonged effect. And some other medications that are manufactured proceeding from nanotechnologies, and they are expected to be of prolonged activity. Well, you do understand that this is all very nice, but the main problem of the therapy is to potentially the problem is that there is a persistent potential activity of integrated proviral DNA. So how to get to this DNA? Actually, there are a couple of approaches. Some suppose and suggest that we should stimulate the natural immunity to help the body to get over it on its own. And there are different options that can be used here. Some researchers suggest to get rid of this infected HIV cells. So there could be some markers developed, and we could just kill these cells. There's another approach, the third one. We should activate the proviral DNA, and that's how the antiretroviral medications will kill it. It's called shock and kill. And another approach that is very promising, it is called the genetic genotherapy. There are a lot of different approaches encapsulated in this one. So the genetic therapy, it has different names, such as genetic stimulation, genetic modification, intercellular immunization. So there are different approaches that are quite different from each other, actually. For example, the genome of the cells that are producing antibodies receive the product that would activate these antibodies. And another approach is that one can code the viral antigens to stimulate the immune response. After that, the T cell receptors are formed, such as CD8, and they will kill the CD4 cells that have been infected with HIV. Another set of genes that can express the microRNA that inhibit HIV, or transactivator of transcription that can also thwart HIV spread, as well as VIF. So all these genes can be transported through different vectors. You've heard about these vectors because of the Sputnik V vaccine against the coronavirus. And what's also very nice is that we can transport the cells that can inhibit the expression of the CCR5 expression. If you remember, there was a Berlin patient, and he had his cells replaced with the cells that didn't have this receptor. And here, nothing should be transplanted at all. We can just adjust the cells of the patient or of a healthy person. So why I said that this genetic therapy can also be used for the purposes of prevention.
If in a healthy person or non-HIV infected, we will process some changes in genetics, it will be not accessible to HIV. So gene therapy is also a prospectful direction for us. And there is also one additional direction or way of work. This is perhaps not the same thing as genetic therapy, because here we will need to work on with all these terms. This is the entrance into the construction that would edit the human genome, like CRISPR, Cas, that are editing the genes within bacteria and cleaning them from the bacteriophages, from the viruses. And here, according to this analogy, we can create some things that would cut out genetic parts, the parts of HIV genes that are built in the genetic code of a human being. So this is also a matter of active work, and all of these directions are developed in different countries. They are on the different stages. There are some first or even second phases of clinical trials. Therefore, there is a research, and it's pretty active. Another question is how we will measure the efficiency of these drugs. Will these drugs be able to cure the HIV infection? Here there is no consensus here, because many think that it will need a combined approach. And here is a pretty picture that I liked. It was published in one of the reviews, that to fully cure a human being, here there will be an antiretrovirus therapy, then certain special antibodies will be injected, or drugs, into the liposomes. Then it will arrive at the fact that there will be a deletion of all active virus parts, and then perhaps it will be necessary to add some genetic therapeutic drugs, and then at the end we can possibly arrive at the full at the full deletion of the virus from the human body. But what will be the result? We are not able to tell right now. Therefore, again, I will state that it is a huge amount of work. It is done in other countries, but it is not so very well financed in Russia. And again, the next thing, we may create all the drugs, and it is done in a rapid way right now. For example, when we speak about the creation of all these vaccines, several months and the drug is ready. But the most severe and the most complex thing is in the field of clinical trials. Therefore, there is a joke that you can see on the screen that before you get your own flu shot or vaccine, you need to test it on people. That means in preclinical trials on animals and then on human beings. And this is perhaps one of the toughest steps, because this is the longest leg for introduction of all new drugs. Therefore, we created, in face of pandemics in Russia, we've managed to open in December the new Research and Development Center, Scientific Center, the purpose of which is to facilitate clinical tests and trials of all these new drugs that we are waiting for. And this is a well-equipped house. As you see on the premises, we have everything to run the clinical tests. And we, of course, want to invite all the patient organizations to search for the people who are willing to take part at the clinical tests, and for them to take part at our works. And I really hope that this longest clinical phase, the longest leg of our tests, will be performed in a more rapid way. Thank you very much for your kind attention. Yes, thank you so much. Now let me represent Mr. Pomazkin Dmitry Vladimirovich. He is the next presenter, and he is representing the Scientific and Research Fund, Gasfond, Russia, with the topic evaluating of demographic consequences of infectious diseases in Russian Federation using the example of HIV infection. Greetings. Our session is providing for this reminding that the quantity of presenters is pretty much the same as the quantity of people who are listening to, and this is the same situation with the doctors and patients in oncology. I want to represent the work that was made in analytical center at the government of the Russian Federation. This work was devoted to creation of mathematical model to assess social and economic consequences related to the HIV. This is not, of course, this is not the first experience in this field, because I think at the very beginning of this millennia, 2000-2001, there was the first model, first approach started to pursue the same goals. And we have a brilliant possibility to take a closer look at what happened during this time and how can we model this. So, let me comment. Could you please help me in managing my slides? Yes, thank you. Now I can see it. This is the contents of my today's presentation. I will tell you today about how we prepared this forecast. I will briefly tell you about the results that we obtained, and I will tell you and show you several directions, new directions in work with scenario models. And briefly, I will touch upon the program part that we've used for this purpose. Perhaps this is one of the most interesting things, and it has quite a potential and can be worked out for the further executions. And we are now going to the next slide. Perhaps I will ask you for certain assistance here. Yes, thank you. Now we can go on. Just a small example from the yesteryears. This was not only the interest of our 2 days' time. When we remember en masse all of our forecasts, the forecasts are not the reality. The reality can change the forecasts, and as Omar Khayyam told, that we are trying to make something up, but the time comes and everything is changed, and we go back to the initial points and try to change our ideas and view. As I told, this version that was made in 2003, in its tendencies and in its overall approach, has pretty much the same result as the previous one, and we are rather optimistic here in the work of our modeling approach. What did we do? As the basis, we've taken the demographic forecast. We had the sex and gender and the age pyramid with use of cohort methods of shift of ages to count the population dynamics. And we've added to this population dynamics this part that would model directly the processes of HIV. Just a couple of words. It's just a lateral idea. What is HIV in view of the processes that we are seeing in our society? In how far does HIV affect the problems and issues related to the sustainable development? By the way, the term sustainable development is conceptuated in the mid-70s of the previous century, and it is now widely used. And HIV, or AIDS, is one of the barriers here that hinders the development and hinders the sustainable development goals. For how much it can be connected or compared to the other challenges like ecological challenges, environmental challenges. This is the problem, or one of the problems, that is solved by this particular model. So, as the basis, we took the demographics, which is the basis, and this demographic forecast. Again, I want to repeat this. We have added the parts that would model directly the HIV infection. Here we have the results of basic forecasts in demography. It was done before COVID. Therefore, all the effects related to the increase of the mortality rates and increase of the life expectancy of patients, and they were not taken into account, although they were significantly affecting demographic processes, because according to the Russian Statistics Agency, life expectancy for 2020 decreased by 2 years from the moment of birth, and this is quite a change. And more or less, this is not a long-term situation. It will be restored, and on a long leg, it will not change the picture. This is just the median data, and we've used the data that would correlate to the median forecast of the Russian Statistics Agency. What did we do? On the basis of this demographic platform, we've built an epidemiological forecast. Epidemiological forecast is a one-sided shift between the phases of health, healthy, HIV, and AIDS. We've used a multi-decrement model with decrement as death, infectious state, and transfer or shift between the groups. And further, I will tell you about the data on the basis of which we've made our calculations. So yes, basically, what did we do? We've used two main hypotheses. The first hypothesis is related to the infection profile. We've took the Form 61 at the Ministry of Healthcare of Russia, analyzed the quantity of infected persons in 5-year groups, and we've built the possibility of getting an infection. I will also tell you that I will distribute the slides later. I will not wait too much here, and I will not tell you about the change in the ages, but here is the diagram that will show it to you more vividly. What is interesting here? Going back to the things that I've mentioned previously, here we see the probability of getting an infection for males and females with gender distribution for the year 2003 and 2019. What do we see here in detail? We see that the amplitude is pretty much the same, but we have a huge shift to the right side, because the probability of getting an infection, this is a process of evolution dynamics, which states that we have just a shift along the age within the groups. We may think about different facts, but this shift in age is very vivid, and we see that along with the time this group is redistributed. That means that infections rate is going to the elderly people and it is diluted. So this is the first hypothesis that was used for epidemiological forecast. And then further, how can we understand these values that we've used, and how can we compare them? I compared them with the probability of death. The blue line here is the probability of getting an infection, and the left side is males, and right side is females. And death is the red line. And we can understand here of the progradients of this event of getting an infection, how it is connected, or how can it be measured with the things like death. So 5,000, that means at the age of 35, 5 men out of 1,000 is dying. And the blue line, which is 2 times less, this is the possibility of getting an infection. And the second picture is also a rather interesting one. Why do I show it here? There is a cumulative, accumulating effect of death related to the age. The red line is, along with the age, how many people are dying, along with the aging, how many people are dying. So as of now, So at the age of 40, we can see that 100,000 people are dying at the age of 40. Then until 60, we have 300,000 deceased person, men and women. And the blue line is showing the annual rate of HIV infections, new infections, I mean. And here we see that because in the elderly groups, the infectious, the infection is at the zero almost. So from 45, we are seeing this plateau. What is the particular interesting here? It's interesting for us to look at this. We've been oriented for the year 2019, according to the data that we had, just that approximately 100,000 infections cases, new infection cases we have in our country, and this is a rather huge amount of infections. What does the model make? It is redistributing the quantity along the age pyramid, adds new cases, and according to the decrements, it is calculating the rate of deceased persons and the quantity of the groups. And knowing the quantity of the groups, we are multiplying or we are meshing this with costs, and we can then calculate the costs for the patients. And the basis here is represented in these curves. So now we were speaking about the probability of getting an infection, and the second outcome is it is also the massive of the initial data. So primary initial data for the distribution. We took the informational bulletin. And on the basis of the informational bulletin, we've made the initial distribution. By the way, it looks like the profile of the rate of probability of getting an infection that we've seen before. And in the year 2019, we've used this form, taking into account the density of distribution, to make the distribution of our initial groups, initial quantity. Initial quantity was 1,050,000 people. So this was just the initial quantity where we added 100,000 annually, and then we followed the dynamics of the disease. And so what did we arrive at? After creating this demographic movement, we've created several demographic scenarios. And I want to state from the very beginning that in these tasks, the task of that kind of class of social dynamics or social tasks, and by this I mean many global systems, it is a rule to work on the basis of a scenario modeling. Scenario modeling is just a set of assumptions that are preserved during the period of a forecast and that define the parameters that are interesting for us for some reasons. Here we were taking into account these apt scenarios, and I will show you later also the other examples. But these, the first scenarios, are the classic ones. So we have 4 basic scenarios that are provided here on the screen, and they are differing by the fact that we were using hypothesis of the connection between the share of the patients who are getting the antiretrovirus therapy and the infected. And we use the 45% hypothesis that 45% of people infected are getting antiretrovirus therapy, and it has not changed a lot. But then in the next scenarios, we tried to build the new parameters on the basis of this hypothesis. We created like the scenario for 70%, for 90% antiretrovirus therapy in the second and the third scenario. And the last, 4th scenario is just a benchmarking scenario for us, according to which we were assessing the state when the probability of getting an infection is at its 0, for example. It's close to the 0. And here in this chart, we see the demographic and financial assumptions that were used for every scenario. I already told you about the demographic scenarios, and financial scenarios are the main costs as follows. The costs at the phase of HIV per annum per person 60,000 rubles a year, and in phase 8 200,000 rubles per year. And these periods of being in phases HIV/AIDS are used within the mesh of the decrement death. What did we arrive at? And then we will see now the graphs. The quantity is in thousands of people, and the financials are in millions of rubles. So the first one, here we can see 5 lines that are correlated to the scenarios that we took into account, and the fifth is the scenario from demographic modeling of the HIV. Without taking into account HIV. What can we do right now? We can see the affection rate of the scenario of the overall demographic losses. And we're pretty sure here that the difference between the scenario without HIV and with due regard to HIV is the difference of 2 million people. That means 2 million people for 30 years is a significant demographic loss that is outlining the task for us, and that is stating that this particular task is very serious for us, and in the long run this problem will only grow. And here is the next graph that shows us how the quantity of economically active population is changing. And here, taking into account the coefficient of economic activities, of course. And here, the effect is 1 million between two scenarios, with HIV and without HIV. And we see here also the affection of antiretrovirus therapy and how it affects the population. Here on this particular picture, you can see the assumptions that we used for modeling on how the probability of getting an infection will be changed along the years. And the lower line, as I told you, the yellow line, is representing the 5% that correspond to the maximum scenario at which we are not getting rid of the HIV, of course, but we are significantly decreasing the processes of HIV. And the previous scenarios are corresponding to the shares of antiretrovirus therapy that are provided on the graph, on the legend. So what did we arrive at? So using all this, the first picture here is the dynamic of the quantity. This quantitative measure is representing a scenario forecast that show how the overall quantity of HIV-infected persons will be changed depending on the share of antiretrovirus therapy for the whole group. And we can see here that if the probability of getting an infection is decreased not so much, the quantity of HIV-infected person is growing, and the gap between maximum and minimum scenario is a relative huge one, approximately 800,000 people. And here there are no serious reverse bindings that are taking into account the antiretrovirus therapy and this probability. This is just the hypothesis that I have showed you before, and this is one of the questions that needs additional clarification, and it needs more serious and a more in-depth study. But just to show this effect, to take a look at the specificity, for example, we've chosen this set of parameters in terms of quantity. And the next is the quantity of the patients having AIDS. And this was the same ideology that was used. We have shown the difference between the maximum and minimum scenario. We have shown that we are achieving a certain high growth, and this initial growth is bound to the fact, perhaps, that we have more affection of our suggestions with the reality. But there is a huge gap between these results also, which you can see on the slide. And it also needs more in-depth analysis here. What about the costs in HIV phases? When we take these 60,000 initial rubles per capita, we see the following costs, and the results are pretty much the same. They are fitting into the logic, because initially the share of the costs is lower, but when we have more antiretrovirus therapy, the costs is getting higher. And taking into account the quantity of HIV infected persons, we see this is just the analogous to any kind of investment. And pretty much the same logic also is related to the costs in the AIDS phase. And the overall costs that include also the so-called additional costs that are related to the prevention, and this was also calculating the growth rate and the inflation. These are not discounted flows. These are the flows without taking into account the growth, but these are the real numbers, and we have an assumption that the rate of the growth is combined with the discount. And just a couple of words about the methods that we see as most perspective ones for the building up of a model and analysis of the versatile system. This is a shift from scenario modeling to the meshing method. What is meshing method in our understanding? Meshing is just comparison of a mass of variants or analysis of specificity for multiparametric tasks. And according to the horizontal axis, we have the year, and the vertical axis is the share of antiretrovirus therapy. And on the lines, you see the quantity of HIV patients infected with the years. You see the solutions. You don't see the scenario lines here. We just may build a trajectory and see how it will be changed. As a matter, it provides for analysis of multiple variants and for the sparing of our time on the analysis, on the work related to the analysis of the results. So this is just a step-by-step analysis, and this instrument is applicable for the tasks related to the calculation and multiple scenario comparison. And the same pretty much about the demographic losses. We see that along with the growth share of antiretrovirus therapy, we see that there are less losses in demography. And this is also a very vivid visualization of the results that we are arriving at. Similar about the death toll of HIV, and just a couple of words about how we did it. So what was the software that we used? We've created and developed the special tool, may I say like this, with the work to work with the big data, so masses of data that are made for the creation of the initial profile of probability, distribution hypothesis of shift. And this program provides for construction of a demographic forecasts. It lets us work with different distributions. For example, we've calculated here some for Russia, overall for Kemerovo region, for Sverdlovsk region within Russia separately. And this program in particular has a very neat graphic interface that provides for the analysis and assessment of the results obtained, and it let us also look on different parameters like scenario and parameters. We can alter the parameters and assess them together with the scenario. This is the tool that is letting us to increase the speed of the process of the analysis of data and provision of the reports. So what are the main outcomes? I don't want to comment on the outcomes related to the dynamic per se, but I wanted to state the following, just one interesting fact. If we will take a look at the influence of the process of HIV infection on the demographic losses, we may compare it to the following. Until now, we are seeing very high mortality rate in the most active parts of the population. And our losses, overall losses, because of the HIV and AIDS, are resulting at 200,000 deaths in the age from 20 to 50 years old, and from 4 to 5,000 in the age from 20 to 60 years. And this is the amount of death that corresponds to the level of mortality that we have right now. But if the mortality rate would be in Russia and the level of the European countries, these losses would be significantly lower. This would be on the level of 150 or 100,000, which means that HIV is also introducing its own toll in these losses, in the losses of most productive population. But it is not so critical as other diseases. But at the same time, I want not speak about diseases. Perhaps it's just I'm not correct here. Diseases also, but other reasons. Therefore, undoubtedly, in terms of demographic development, in terms of the decrease of losses or losses in the demographic capital and demographic stock of the country, we need to work with these problems. We need to work out solutions and study this. And this was just an example of how we could use different instruments, also software, to make this analysis. I think that's all from my side. Thank you very much. Thank you so much. Unfortunately, we took a little time from the other presenters. You are not getting some additional questions. It's okay for me. But if you will want to, you may answer the questions later. And the next presenter is Gashnikova Nadezhda Matveyevna, with the topic Specifics of Molecular and Epidemiological Incidence of HIV in Kyrgyz Republic.
Distinguished colleagues, good afternoon. I need to manage my presentation, to control it. Okay, I think it works. Thank you. This research has been done in cooperation with the professionals of the Republic Center and local centers in the Republic of Kyrgyzstan, as well as with the participation of the employees of Vector Scientific Center. The main goal of our research is the molecular and epidemiological analysis of the development of HIV epidemic in the Republic. We had to understand the inner characteristics of that. We need to comprehensively study the clinical and epidemiological data of the patients, as well as the viral characteristics that were marked and identified among those patients. We hope that this understanding will allow us to develop some proper measures that will result in some great efficiency of preventive activities, and they will also help us to increase the effectiveness of ART. Well, we have, of course, the territorial specificities in Kyrgyzstan, and we've chosen Bishkek, Churska Oblast, Osh, and Oshskaya Oblast, or regions. And the employees of the AIDS Center gathered the patients for this study, and they analyzed the data from these patients. It allowed us to understand that the collection of data and samples allows us to properly analyze the HIV situation in this country, I mean in Kyrgyzstan, and to draw the subsequent proper conclusions. So in the sample of the viruses that was studied, they were specific for the Central Asia countries, and they are called circulating recombinant form. And they accounted for 59.8% CRFO2 AG, and the HIV of subtype A6, which is quite close to the Russian viruses, accounted for 33%. There are also some minor variants and options and we've seen that the most majority of the viruses was among homosexual contacts. When it comes to heterosexual contacts, we've got some cases that were brought from Russia, and as well among the heterosexual contacts, we've indicated some unique viruses or unique recombinants that occurred because of the repeated infection of people with the recirculating viruses, such as subtype A6 and O2AG. When it comes to homosexual contacts, we saw that the picture was quite a different one. There prevailed the A6 subtype. The second place was occupied the recombinant virus 02AG. And when it came to minor variants, the picture was quite different. The broad viruses, the broad European viruses was registered there, and also there was appearance of recombinant viruses that appeared because of the repeated infection of people with the 02AG and A6, and as well as the variants and options that were brought from the outside the country. For the main genetic variants of the virus, we comprehensively analyzed the epidemiological characteristics and clinical characteristics of patients that were diagnosed with these viruses. So for A subtype, we've seen that the viruses that were diagnosed among the population in Kyrgyzstan, fortunately, I don't have the opportunity to show you, but I'll show with my friends, or with my hands, sorry. Fortunately, the sound is coming very poorly. So the viruses in Bishkek and in Osh are marked by blue and red, and you can see the picture. So the blue line is viruses of Bishkek, and the red line is in Osh. The green line are viruses that were identified in Jalalabad. And here we see that the viruses that were diagnosed in Kyrgyzstan can be organized in clusters, but those clusters are not statistically supported. We see that there is a very heterogeneous picture of these viruses, and they are mixing with the viruses that were diagnosed in Russia and other countries. This means that the virus of the A subtype comes and is brought to our republic from the Eastern Europe as well as Central Asia, as well as it circulates inside the country. For A subtypes viruses, we developed and designed a phylogenetic curve, and we analyzed the time when this virus first appeared and when it started to spread. Well, the spread of this virus started in 1995, and we see that up until 2015, on an annual basis, the spread of this virus has been increasing, and after 2015 we monitor the negative dynamics in the spread of this A6 subtype. As to another main variant in the Republic of Kyrgyzstan, the circulating recombinant form 02AG, well, the situation here is quite different one. Here on this diagram we can see 4 clusters, and they're marked with the letters A, B, C, D. And these clusters are statistically supported, and it means that these viruses were brought to the territory of Kyrgyzstan, and after that they started to spread inside the country between the citizens of our state. Here you can see the phylodynamic curve of the spread of this type of the virus. And it shows us that the beginning of the epidemic that was caused by this virus happened in 1997. And we see that the clusters of the sources of this virus that were formed, it all dates back to 2000 and 2003. And the clusters, those were the Osh clusters, and clusters in Bishkek appeared in 2005 and 2006. One needs to say that the general analysis allowed us to identify the connection, a time connection of the drug traffic across the northern way. So the appearance of the sources of the virus coincided with the narco or drug traffic across the northern way. So we suppose that the drug traffic resulted in the bringing to the Kyrgyzstan of this virus. And we believe and conclude that the main factors that started the epidemic at the very beginning was such factors as the involvement of our country in the drug traffic and the penetration of these viruses inside the Kyrgyzstan to those groups that took drugs. So these drug-consuming people in 2000s, among them, 80% were HIV positive. Another aspect is the labor migration, added and supplemented by the low level of awareness. So in the beginning of 2000s, there were some outbreaks of HIV, indeed, and it resulted in the spread of the virus inside our republic. So one needs to state that this virus that we call the Central Asia variant of the recirculating recombinant form 02AG, it spreads only in the Central Asia countries, such as Kyrgyzstan, Kazakhstan, Uzbekistan, and Tajikistan. We conducted a full-fledged phylogenetic analysis of all AG viruses, those that we could collect from the international database. We added it by our sequences that were decoded. And this analysis shows us that indeed there is a specific population of the virus on the territory of the Central Asia. At the very lower part of this diagram, we see the appearance of those viruses that are already spread in Africa. This is an absolutely different type of phylogenetic tree. And those viruses that are identified in the Central Asia, they build their own branch, but also within this branch, there's statistically significant group of the subtypes of this virus. So the Central Asia countries see the emerging of its own epidemic with its own viruses, and these viruses need to be studied in the future, and it will allow us to understand whether they are diagnosed properly, are there any characteristics of specifics of this virus when it comes to ART. And additionally, within this work, we analyzed the transmission clusters of HIV. So whether the transmission of this virus is identified among the population that has been studied. In the group that we analyzed, we found 59 possible transmission clusters. And it's evident that the majority of them, 39 clusters, were identified in connection to 02AG. And this is another confirmation that this virus is quite actively present in our country, in Kyrgyzstan. And 19 clusters contained viruses with medication resistance or multiple medication resistance. And it tells us, it demonstrates that the transmission of primary resistant viruses is also possible. So what conclusions can be made of all this? the growth in the HIV infection is due to those viruses that brought to the country, but at the same time, the inner circulation of HIV infection adds more to the pandemic and to the spread of this situation. One of the most efficient measures on the prevention of HIV infection spread is the decrease of number of people that have quite a high viral load. And when we studied this viral population, we couldn't help but noticing that there were some mutations that are connected to the resistance, the development of the resistance of this virus. We conducted this kind of analysis, we described all these mutations, but I don't think that this is the most important element of our work. The most important one is that our molecular and genetic research of the virus allowed us to identify some gaps, loopholes, when it comes to the treatment of patients, as well as the analysis of the therapeutical efficiency. Each time when we discuss the results of the research for another group and sample of patients, we analyzed all the characteristics as well as clinical characteristics of patients. And we've noticed that patients that administered ART on a regular basis, who were respecting all the rules, well, they have the proper viral load. And the analysis of the resistance allowed us to identify some viruses with the mutations among only 30%, and or from 15 to 30%. And when the ART was administered, it worked quite a lot for the upcoming 5 years and more. But it raised a suspicion, and we suggested that those patients were saying that they were administering the therapy, but they didn't do it in the reality. And another significant and meaningful conclusion that we drew is that among those people who haven't got any identifiable viral load with the test systems over 500 copies of RNA, from 15 to 30% of the viruses were resistant. As to the hidden refusal from ART, actually this was confirmed because patients who were coming to a doctor for another dose of ART indeed confirmed that they didn't take the therapy for many years. They just took the medication but didn't administer them, because those medications were handed out jointly with the motivation packages. And as to the second suggestion about the test systems, indeed, these test systems didn't take into account the low reproduction of the virus, and they allowed to miss the initial development of the viral resistance. And so the AIDS Center analyzed additionally some other factors and identified them when it comes to the inefficient therapy, such factors as the frequent change of medications, drugs, also the untimely corrections of the therapy among children. All these factors that were identified were used for the development of new programs aimed at increasing the motivation of patients to administer the drugs, as well as to get rid of the gaps and loopholes that we identified before. And the data that we got from the project has been actively used by the employees of the AIDS Center to tell the patients that a repeated infection is quite a dangerous one. Also to tell them that labor migrants can bring in some new viruses. So all the information that we got from our research, we modified it into a user-friendly form, and doctors were telling the patients about all this. So the joint research allowed us to implement the new molecular and epidemiological approaches It helped us to understand the epidemic, to understand the epidemiological process, as well as to develop some new and efficient measures. And one needs to say that all this was quite new one for us, not very understandable, but very useful. Back in 2016 and 2017, the employees of our aid center didn't have any experience in applying these methods, and they didn't analyze the inefficient therapy. And I do hope that this experience that we got jointly added to our main efforts. And currently, Kyrgyzstan gains some good results. If we take a look at the data of 2021 of patients with ART, we see that more than 80% of cases we identify so-called non-identifiable viral loads. So the therapy is efficient. Thank you very much. And thank you very much for your report. It was very interesting. Thank you for telling us about the benefit of molecular and epidemiological measures. And our next report will be on the using molecular and genetic methods for HIV surveillance. It will be presented by Dmitry Kireev. Thank you very much. Shortly, I'd like to comment.
Recently, together with Natalia Andreevna, we were speaking about the originality CRF02G, and we arrived at the conclusion that perhaps there was a secondary recombination of the European CRF02G and recombinant of A103G, and CRF03G is the Asia recombinant of A3G. The recombination scope are pretty much the same, but CRF02G is just a different one, so this could be the case. Distinguished colleagues, give me 6 hours to cut down a tree, and I will spend 4 hours to sharpen my axe. This is my initial status, and the majority of the slides I will show you about, I will tell you about the axe. Here, about molecular genetic methods, I will speak about sequencing of HIV and further analysis of these nucleotic chains. Classically, we are sequencing according to Sanger, and we are using right now also mass parallel sequencing, and these new gadgets are providing for more patients by tens, dozens and hundreds of times. And generally we are speaking about sequencing of not all the genome. We are sequencing only main genes of protease, and the second one because there is the main question, and we are sequencing with practical goals to understand the sustainability and susceptibility. And according to these new gadgets that have more power in them and that have more possibilities to test as more people as possible, during the last 10 years we collected vast majority of nucleotic chains, and this quantity of nucleotic chains is providing us for conduction of a serious molecular biologic research. The sequencing share people of the living in Switzerland is about 50%. In other countries, there are about 20%. Unfortunately, in Russia, there is only 1% of such people who've got their sequencing, and the density is playing here a very important role, because when we will want to conduct a national social survey, naturally, it is not enough for us to speak with 10 or 100 people. We will need to speak and to make a survey of a share of population. Also here, for serious research, we need a density of collection of 15, 20 or 30%. It is not recent research that epidemiologically connected patients have similarities in viruses by 97% similarities, and this is logically because the human being can provide only the virus that it has in itself to the other recipients, and after years these viruses tend to remain more genetically relevant to each other as the others. We are comparing on the basis of phylogenetical analysis. We arrive at phylogenetical 3, and 3, if we see that the several samples of virus are close to each other and they are differentiated from the other, we name it as a molecular cluster, and we mean that this molecular cluster is a part of an epidemiological cluster or epidemiological chain. And mainly speaking, we may see it as a phylogenetic 3, as you can see it on the right, or we can represent it in a more standard way as the clusters that you see here. And we can also understand that the more consequences and chains are in cluster, the more active is the distribution of an infection. And if we put characteristics on this cluster within other data of patients like gender, age, region of living, date of infection, or the way of a transfer of this infection, we can characterize these clusters in a more full way, and we may understand and define how the epidemics is developing. And these clusters are taken from the small size, and here how a more serious work looks. This is a very important picture, but you cannot understand anything here with your eyes, because generally, for analysis of these clusters, we use specialized computer and bioinformatics programs. We may say that the start of use of phylogenetic analysis and molecular genetic methods in the scope of HIV infection was started in the 90s, when it was started to make an understanding of the outbreaks of infection. One of the cases is the dentist case in Florida. The dentist who had the HIV infection, he was sequenced then with his patients that were also getting a virus from him. And then in 15 years, there were tens or dozens of this work published, and hundreds of them were conducted. And after 15 years, there was a norm and regulative document that is stating that the use of phylogenetic analysis can be used as evidence in criminal investigation of HIV transmission. And as I may state here, the presence of this document of HIV forensic is a good proof that phylogenetic analysis is a firm and sustainable instrument in criminalistics. And we have also this document in Russia. It's a bit, it was created a bit later than in Great Britain. 15 years, in 2015 also, the scope of use of molecular methods in epidemiology is broadening. This is not only an epidemiological analysis, this is phylogeography, study of the distribution of HIV, phylodynamics, study of the speed of the virus in on the planet Earth and in the several susceptible groups, assessment of main epidemiological parameters like basic efficient reproductive affection and so on. And this is also the definition of efficiency of diagnostics. That means timely manner of HIV diagnostics, and it is also the brilliant possibility to assess the efficiency of preventive works. We all know this research series of researches N equals N, where it is stated that N means non-defined doesn't mean non-virulently loads. If you don't have a virus load, you cannot infect your partner. And this was also the proof that was phylogenetically proven, but only by means of molecular methods we could prove that the partners were getting their HIV not from their partners with non-detected viral load, but from third persons, from the other people. Just a few examples to this. The first example of how we could trace the patient zero, the patient from whom the epidemic started in the Northern Americas. It was 1969, 1970, how the epidemics was developed in the USA. This is a very interesting work, 1970s in patient zero HIV-1 genomes illuminating early HIV/AIDS history in North America. This is also the case for the USSR. There is a pretty similar work and paper related to the USSR history of first HIV in the USSR. And there was also the Kinshasa studies about the 1920s and molecular methods that studies Kinshasa case, and practical work that was done on HIV-infected patients from Uganda that are living near the Victoria Lake Victoria, and there is a very interesting population with people living with HIV because these are the farms that are characterized by huge affection by HIV. Up to 50% of adults are infected. And the other villages have also a huge affection rate, but not a catastrophic, from 10 to 20% in adults. And the researchers were thinking that these hot spots, real hot spots here, are the initial ways of transmission of infection near this lake. And the specialists sequenced the significant quantity of people out of 4 villages. They compared these 4 initial villages with the 36 other villages, and they've seen the vice versa picture. It turned out to be the fact that firstly, this is the domestic epidemics. That means this is epidemic within an epidemic. So new cases within the villages, these 4 villages, and between the 36 villages, they are arising within due to the HIV-infected people who are living at the side of each other. And the imports of HIV is then made through the migrants, so HIV-infected migrants who are going there for fishing. So this is just a very important result of research, and it has a great basis, and it is published in the last year in Lancet. And also the third example, this is an old work that was published in 2016 by the great Canadian explorers with Richard Hannigan. And this is a real-time monitoring of a transfer of HIV because of the hot spots or hot outbreaks. What did they do? They created an online basis where after nucleotic chains, a study, and I need to say that in the developed countries, when they are sequencing patients before the start of the antiretrovirus therapy, the sequencing is made or just straightforward after the diagnosis is set. So after the diagnosis is set, the patients are sequenced, and there is a digital database which is filled in by the data of this particular kind of patients, with the data of patients, and then regularly, once a month, they are conducting phylogenetic analysis. They are providing for assessment of molecular clusters, and they define the clusters per se. And the researchers made the clustering on the administrative regions in Canada. In green, you see the clusters with 0 outbreaks in the last month. Yellow or orange, 1 or 2 new cases of infection. And red color is 3+ recent cases. And for Canada, 3+ is a huge quantity of infection. So they've seen this administrative region, and during the last 3 months, there were 11 new cases of infection. And then these results were transferred to the practitioners, that means to the practical healthcare, to the epidemiologists, and these HIV-infected persons were found. 1/3 of them were not encompassed by medical support, and half of them were not taking antiretrovirus drugs. And this was corrected naturally. All of them were taken into account by the governing bodies and authorities. The majority of them started immediately their antiretrovirus therapy, and according to the results, in 12 months in this region, they've seen 12 new cases, recent cases that were close to the cluster. That means that the quantity of new cases were decreased by 3 times after these anti-pandemic events. And this is just a great example on how molecular means can help you. And then let us go to the epidemiological surveillance. In 2003, 2016, there was a wave of such works and papers. Now there are more than 500 of such works and such researches publishing related to the molecular epidemiology of HIV. And in 2018 there was the first norm and regulating document that was published by the American CDC on how to detect and respond and analyze HIV transmission molecular clusters and what the practitioners in healthcare should do with this data. And in 2018, there was the second draft version. I will stress it out that it's a draft version of this guide. And already more than a dozen of the articles or papers that are related to the molecular epidemiology of HIV that are methodologically using these particular instructions that were drafted in this guide. And this is just the fruit of the last several years. And I think we are on the edge of the beginning of the high-scale introduction of molecular methods into the practical epidemiology. Just a little bit about our national bases in different countries. In different countries, developed countries, there are national databases. For example, Great Britain, UK HIV, that includes more than 150,000 sequences. CDC, and there is also regional ESR, a regional database, which consists of a huge amount of countries of Western Europe, Eastern Europe countries. There is also a Russian database, domestic for us. This is a microscopic compared to the other databases, but we try to build on this. And the function of these databases is to preserve and store the information on molecular data, depersonified data of patients, and further analysis. And at the end of my presentation, I want to state that the molecular methods, as I may state, is a powerful instrument that is more actively used in epidemiology. And the nucleotide chain of the virus is a very important objective characteristic of a patient. And here I want to speak in detail about the objective characteristics, because the patient may not know when he or she was infected. Patient may deliberately lie about the way of transmission of the infection, but nucleotic chain will not lie to you. This is the parameter that cannot lie just. And if you have a huge quantity of nucleotic chains for a certain region, to analyze this nucleotic chains, you may trace the patient, you may say what is the group that is represented by the patient, and you will know more than the patient, really. And providing for storage of the sequencing and nucleotic chains that are now in place in the country, it will provide for a better consultancy for you. This will happen not in 1 month or not in 1 year, because this information has no shelf life. Also, the information related to the people who died already with HIV, who are not a part of epidemiological process. As of now, the data of 10 years old, for example, it is also very necessary for us to restore the data on evolution of the epidemics in the region under research. And it seems to me that the further development of epidemiological vigilance is also connected to genetics, to bioinformatics, because without this particular knowledge, we cannot analyze everything. Thank you very much for your kind attention. Artyom Tkachuk, are you here in the hall? Because here in my agenda there is the last reporter who is here. So he's not the hero who would sit for the whole list of our presenters. Do you have any questions? Do we have any questions to the presenters? So, may I put a joke at the end? Look, there is a mid-Asian stem that was seen. Perhaps I would think that it was taken from some Sasquatch. There is some joke also out of the micro, but still, I may state, thank you very much for this very interesting reports. Do we have any questions still? Are we happy with today's session? Then let me thank all the presenters. Really, we had a versatile set of reports and presentations, but I think that many of you had particular interests in this topic. There were not many people offline, but I hope there are many people online attending to this event. Thank you very much to all of you for your patience, and we wish you good luck. Thank you.